I'm gonna hit record. We can go ahead and get started. Um, Hello, everyone. My name is Phyllis Leverage. I am the Western Slope Outreach Coordinator for Parkinson Association of the Rockies, and I'm so glad that you could be here today to learn more about exercise and mental health as they pertain to Parkinson's disease. I have a few announcements before we begin. First of all, we have two summits called Thrive Together that are scheduled to educate attendees by hosting speakers from different specialties, including social workers, psychiatrists, neurologists, palliative care physicians, and other professionals to speak. These conferences empower attendees by providing resources on how to thrive with Parkinson's through local exhibitors and sponsors. So the first Thrive Together Summit will be in Northern Colorado on April 25th from 9 to 1:15 at the Fort Collins Senior Center. And Thrive Together on the Western Slope will be on May 16th from 9 to 1:30 at the Community Hospital in Grand Junction. You can see our website for registration and links, or you can just send me an email. We also have free exercise classes and support groups throughout Colorado and Wyoming. So just see our website for services near you. And just a few housekeeping notes. If you could please mute your speakers or mute your mic. I'm sorry, just to minimize background noise. I'll try to keep an eye on them from my end as well. But and then if you have a question, we can either. I guess Sarah, do you want to take questions at the end, or do you want to take questions as you go, or how do you want to do that?
Yeah, there are a few points as I conclude different parts that I can pause and ask for questions. So there will
Okay.
probably be three or four points throughout where people can pop in and ask questions.
Perfect. Okay, so we'll just when you have a question, just unmute yourself when she gets to a point like that. And now it's my pleasure to introduce our first speaker today. Her name is Sierra Martin, and Sierra is a physical therapist with a specialty certification in neurologic diagnosis. She's incredibly passionate about improving the lives and movements of those that she works with. She's had the pleasure of growing up in Colorado and loves to help people remain active and explore the area that we're privileged to live in. She has spent many hours working with individuals with Parkinson's disease and finds it incredibly fulfilling to find what motivates each and every one of them to be able to utilize exercise as the medicine it is. So we're honored to have her here today to share her insights on exercise and Parkinson's disease. So please join me in welcoming Sierra.
Hi, everyone. As Phyllis, am really glad that you are all here. And hopefully, as we go through this presentation, feel you understand why I'm saying this. But I think you being here today and hearing this information is arguably the most important thing that you could be doing for yourself as someone with Parkinson's or a care partner as someone with Parkinson's, because exercise really can be such a foundational and key part of management of Parkinson's disease. So we will jump right in. And like I said, there's going to be a few points that after we move from section to section, I'll pause in case anyone has questions. But if you have a burning question that can't wait, go ahead and unmute yourself and talk over me, because I want you all to be able to get all of your questions answered today as well. Let's see here. There we go. All right. So just for a little bit of background about myself, I got my doctorate of physical therapy from the University of Delaware, and then my neurologic specialty education from the Johns Hopkins Neurologic Residency. And currently, I'm working at Valley View Hospital in Glenwood Springs, Colorado, as a neurologic specialist, and then also helping with pathway facilitation for all of our neurologic diagnoses. And I've always said, as I have grown in my journey of treating neurologic diagnoses, that I love working with individuals with Parkinson's. You all just have such a unique passion for improving your health and are really dedicated to what you're doing, and it really makes my job a lot more fun and rewarding. So I'm very glad that you all are here. To give a bit of an overview of how the next 45 or so hour is going to go, we're going to start by just briefly overviewing the mechanism of how Parkinson's specifically affects movement. I know in the prior two presentations that you had, you went into much greater detail about the mechanism of Parkinson's disease and how the medications affect it and all of that. So we're just going to gloss over this and then move into the benefits of exercise for a variety of different categories of exercise. And each of those categories will talk about the parameters. So exactly what you should be doing in the nitty-gritty details, as well as providing some example exercises. These, again, are just going to be dipping your toes in if you're looking to get started with something right now. And then I do also want to talk about when it's appropriate to seek the help of a rehabilitation professional. So to begin talking about how Parkinson's disease affects movement, you all know from the previous seminars that you've been part of that Parkinson's disease affects the health of cells in our brain that produce dopamine, which is a very important neurotransmitter and helps in the production of movement and regulation of body functions. So this image here that's on your screen is showing you the specific part of your brain that's impacted in Parkinson's. So if you're seeing these red lines here, these are dopamine producing cells in that specific part of your brain that's affected, called the basal ganglia. And you can see as we're moving through stages of Parkinson's disease that the volume and number of those cells is decreasing. So having fewer of these cells that produce dopamine is how our movement is impacted. Dopamine is really important in movement initiation, movement coordination, and movement termination. So even stopping movement sometimes can be impacted. So I often describe this part of the brain to my patients as our brain's air traffic controller or a crossing guard for traffic. This is not the part of our brain that produces muscle strength or produces movement in that way, but it is the part of our brain that helps to coordinate what parts of our body are moving, what parts of our body are not moving. If I want to bend my elbow this way, this part of my brain is telling my bicep muscle, okay, go ahead and contract to bring your hand up. And my tricep muscle is then getting the message from my brain, you need to turn off so that your elbow can move in this direction. So sometimes the lack of number that we're seeing here in this image is creating a lack of coordination that impacts the movement output, just like having not enough air traffic controllers would make an airport incredibly chaotic with people doing things they're not supposed to, planes not leaving when they're supposed to. The same thing happens with our movement when this part of our brain is not functioning properly. So, like I said, these are some of the symptoms that can result from the lack of that dopamine and those cells that produce dopamine. These are, symptoms that I know you guys have talked about in your previous presentations, but I just wanted to give a little refresher. So when I reference, motor symptoms or non-motor symptoms as we're talking, you have these fresh on your brain. So we know our hallmark motor symptoms are slower movement, tremors, rigidity and stiffness, and balance impairments. And then there are lots of other motor symptoms that I didn't list here, but some of the other ones that commonly come up are this word retropulsion, which means that you feel like you're being pushed or falling backwards, dyskinesias and dystonias, which are forms of extra unwanted movement, and then freezing, when that message for movement is getting stuck by an air traffic controller that never released it to go. So we also have non-motor symptoms of Parkinson's. So these are, the ones that are listed here. And there are many others that are not listed here, but these are some of the most common ones that affect people. So what does exercise have to do with this part of our brain and all of these symptoms? As you may have heard in some of your previous talks, exercise is the only disease-modifying tool that we have at our disposal. So I think in your last, talk, you were learning a lot about different medications and how they function and what they do for you. So carbidopa, levodopa, other dopamine replacement therapies, MAOB inhibitors. These are incredibly helpful medications, but they all function to help provide your brain with the dopamine that it is not producing itself. So they're a band-aid. They're saying, you don't have enough dopamine, here's some more dopamine for you. But unfortunately, we don't have any medications right now that are actually impacting the root cause of this disease and preventing that cause from progressing, except for exercise. Research has demonstrated that exercise in and of itself can delay and slow down disease progression. And in some cases, it's been shown to even improve the health of the cells that are producing dopamine. So, all this is to say that you're going to get to that point later where you're having functional difficulties from your own cells not producing enough dopamine. So, even if we take exercise in a silo where we do not consider its effects on the disease process, exercise can still have incredibly beneficial effects on function and mobility, which then for you translates to maintaining independence for longer and improving your quality of life while you navigate this diagnosis. Another thing to consider is that research has demonstrated that individuals with Parkinson's, on average, exercise about 30% less than their age match norms. So, if any of you in here are 65, then you'd be considering yourself as a 65-year-old individual who has Parkinson's versus a 65-year-old individual who does not have Parkinson's. And the individuals who do have Parkinson's are typically exercising, like I said, about 30% less. So that means that we have to be incredibly intentional with how we implement exercise. And there are lots of very understandable and very good reasons for this, some of which are a higher fear of falling during exercise, increased difficulty with movement, other medical comorbidities that can be impacting this, as well as depression and anxiety, which are common parts of Parkinson's. And Parkinson's can affect your motivation as well. Motivation is very heavily regulated by dopamine. So we're asking you to do all this exercise and then kind of taking away the tool that you need to do it. So we are going to talk about strategies for managing low motivation for this. But there are lots of explanations as to why people with Parkinson's exercise less. It just means that we have to be more intentional about incorporating it. One of those factors in regards to exercising less is that the research has also found that individuals who did not have falls in the last year were exercising about 30% more than individuals who did have falls in the last year. And this can be a little bit of a chicken or the egg situation where we're not sure, are people not falling because they're exercising more? Or are people exercising more because they have a lower fear of falling? And the reality is both of those things are probably true. Now, as we start getting into the next kind of set of slides that I'm going to work through, I do want to just give the caveat that some of these slides are very text heavy and have a lot of information. I provided this here for you solely as reference material. All these talks can be posted online. I know the Parkinson's Association has a YouTube page where the previous talks can be found. So I don't want you to feel that you have to remember all of the information that's conveyed right now, but you can come back to this when you feel you've digested a little bit more and you're ready to look at it again and get some of that information again later. So it can serve just as a reference point later down the road. I also want you to keep in mind as we start talking about the quantity of exercise that we should be doing and all the different types that can be beneficial, is that each and every single one of you is going to have a different starting point, a different personal relationship with exercise, and a different thought process as you're hearing this information. If you're someone who has exercised regularly throughout your entire life, you may hear this information and be like, great, I'm already doing 70% of this. Getting that last 30% in is going to be easy. If you're someone who exercise has never been a part of your regular routine, this might feel incredibly overwhelming. So I want you to keep in mind that these are recommendations for the standard Parkinson's patient in the ideal circumstance. Your symptoms that you may be experiencing may not be completely standard, or may not, you may have barriers to being in the ideal situation to implement all of this right now. So while we're talking about this, just keep in mind that you can start with bite-sized chunks, a portion of this, and gradually work your way up as you become more comfortable. So this is a little bit of a roadmap for the types of exercise that we're going to talk about. And the main categories we're going to go over are aerobic exercise, which is like cardio activity, getting your heart rate up, breathing hard, progressive resistance training or strength training, balance training, flexibility. And then I did just want to mention functional task training and problem specific kind of interventions, which we won't talk about as much, but I will bring up when we talk about physical therapy management. And as soon as we get through the section on aerobic exercise, I'm going to pause then if anyone has questions. So just hold them in your brain until then. So, aerobic activity, why does it matter? Aerobic activity has a lot of benefits in and of itself. So it's improving our aerobic capacity, it's improving motor symptoms of Parkinson's disease as well as non-motor symptoms. It can improve functional capacity and quality of life. It also has additional benefits where it's been shown to upregulate dopamine. Now, that may mean nothing to many of you, but basically that means it can help us produce more dopamine as well as help our brain use that dopamine more effectively. It also can help with increased endorphins. And then something else where you don't need to remember these words, but it increases something called brain-derived neurotrophic factor, which is a really fancy schmancy way to say that it makes our brain more neuroplastic or receptive to change. It helps us learn, it helps us improve, the way we interpret new information and grow. And I think this information that I was about to share is on my next slide. Well, not quite. So the other thing to consider about aerobic activity is when we talk about exercise in particular being disease modifying, the bulk of that research is coming specifically from studies done with aerobic activity. So I want you to think about aerobic activity as the first building block in your exercise pyramid. This is one of the most important parts when we're thinking of exercise, because it is where we get that data that exercise can delay disease progression. So, thinking of the studies where we got this information, we have to make sure that the conditions under which we're doing aerobic exercise are getting close to what they did in those studies so that we know we're going to get the same result. I have two categories up here because I know that some of the information you got was information from the American Heart Association, which is a really great starting point. And these goals for exercise are outlined for everyone. These are not Parkinson specific, but they are recommendations on what every person should be doing to maintain optimal health. So those are recommending 150 minutes per week of moderate intensity aerobic activity or 75 minutes per week of vigorous aerobic activity. And we are going to get into how you know if you're doing moderate or vigorous aerobic activity. But what that tells us is that higher intensity exercise packs a little bit more of a punch than lower intensity exercise. When we go and look at the Parkinson's specific research, the studies that showed a delay in disease progression. We're using a framework where these individuals were exercising for 30 to 40 minutes at least 3 times a week. So this is a little bit lower of a total volume in the 90 to 120 minute range. If that feels a little bit more approachable than 150 minutes or 2.5 hours. Now, there are some caveats to this that feel kind of like extraneous details, but they do make a difference in how you implement this activity in a day-to-day basis. These 30 to 40 minutes did not include the warm up and the cool down for these exercise periods. So if you're doing a stationary bike and you're doing a 5-minute warm up and then a 5-minute cool down at the end, those 10 minutes don't contribute to that 30 to 40 minute total because it's 30 to 40 minutes where you're in that moderate to high intensity zone. And then the other thing that we know is that we can break apart this 30 to 40 minutes on a given day. It doesn't all have to be done at once. And I often refer to breaking up exercise like this as a movement snack instead of the 30 to 40 minutes at once being like a whole meal. So you can pepper it in throughout your day, and there are a lot of benefits to that as well. But if you are breaking it up, then not including your warm up and cool down, you should be doing this for at least 10 minutes at a time that they were talking about in this research. We also know, same thing here as what we see from the American Heart Association recommendations, is that intensity matters. So if you're exercising at that more vigorous intensity, you can probably be closer to that 30 minutes recommendation or 90 minutes total. And if you're exercising at a more moderate intensity, then you'd probably want to shoot for the higher end of that range towards the 120-minute total. So, like I said, if I'm telling you to exercise at a specific intensity, we need to know how to measure the intensity of our aerobic activity. So there are two different ways that we can do this. One is utilizing information from our heart rate, and the other is using something called an RPE scale, which is also known as your rate of perceived exertion. So we're going to talk about both of these and how to get this information and how to utilize it. If you are wondering, how am I supposed to be measuring my heart rate? There are a lot of different tools to utilize out there. You can take a manual heart rate, which is probably the most cumbersome of these options. If you are looking to purchase a tool to help you with this, the most cost affordable one is going to be a pulse oximeter, like you see in that second picture there, where this measures your oxygen saturation, but it will also tell you your heart rate. And this is good for like spot checking. So if you're going for a walk on your treadmill or outside, you can just check this every few minutes and get an idea of where you're at. If you're using exercise equipment, most of them have heart rate sensors on them. And there are also other wearable devices that you can get if you're like, I'm really invested, I want to set myself up for the easiest way to do this consistently, then I would recommend either a sport watch, like an Apple Watch or a Garmin watch, or a wearable device that goes around your bicep or your chest. These both give you continuous readouts of your heart rate if you're in an exercise setting with them. So you don't have to refresh it or do anything that's a little bit more cumbersome. This may look like an intimidating slide, but we're going to break it down step by step. And this is one of those slides that's really good to come back to as a reference for later. So don't feel overwhelmed if you're like, I'm not going to remember all of that. That's okay. You're not meant to right now. So we're going to start by looking at finding how you know if you're in that moderate intensity range. So moderate intensity exercise is defined as 65 to 75% of our maximum heart rate. So to find out what this range is for each of us, we need to figure out what our maximum heart rate is. So we're going to use someone being 65 years of age as an example. And there's a simple equation that's applicable to most individuals for finding a maximum heart rate, and that would be to take the number 220 here. I don't know if you guys can see my cursor or not, but to take the number 220 and subtract your age from that. So if we do that with our example of 65, we get the number 155. So this would function as the theoretical maximum heart rate for someone who is 65 years of age. Then we're going to use those percentages and find the lower range of where your heart rate would be if you're doing moderate intensity exercise. So then at that point, you would take 0.65 and multiply it by your maximum heart rate. And so if we do 0.65 times 155, it can be roundable to 100. I think it's like actually 100.25 or something like that. But keep it simple, just round it for yourself. And then we're going to take our maximum heart rate and multiply it times 0.75, or that 75 percentile, to find our upper end of the range. And that would give us about 116 beats per minute. If you want to keep it really simple, you can be thinking, okay, if I'm exercising and my heart rate is between about 100 and 115, I'm in that moderate intensity category. So then this slide is looking at the high intensity category, which is not very different from moderate intensity, but we're now looking at a heart rate range that is 75 to 85% of our maximum heart rate. So you can keep your 0.75 number and then just find your upper end of this range by multiplying your maximum heart rate by 0.85. So if we're using the 65-year-old as an example, their upper range, or 85% of their maximum heart rate, is going to be 132 beats per minute. So if this were me, I'd be thinking, okay, from 100 to 115 approximately, if my heart rate is there, that means I'm exercising at a moderate intensity. If I'm between 115 and 130-ish, I'm exercising at a vigorous or high intensity. So that is one way of figuring out how intensely you're exercising, but there are times when RPE is more appropriate to use, or you can use this method if you're just like, that is way too much for me. I'm not going to be doing all that. Give me a different way to figure out how intensely I'm exercising, then you can use RPE as well. So when we were talking about those non-motor symptoms, one of them was autonomic regulation, which is also known as how our body regulates our heart rate, our blood pressure, a lot of those other functions. And that can be impaired in Parkinson's disease because of some of the neurotransmitters that are impacted. So you would know if this is impacted in you, potentially because you would have symptoms like getting lightheaded when you stand up. If you've ever experienced that, then you may say, okay, just going to make a mental note that my autonomic function may be impacted as a non-motor symptom. Not everyone's autonomic function is impacted, so this isn't going to apply to everyone. The reason why this matters for tracking intensity of your exercise is that this can also come with a blunted heart rate response, meaning that in these individuals, because of how our nervous system is impacted, even if you're exercising intensely, your heart rate just isn't going to reflect that as much. It's not going to rise as much in response to that exercise, which can then make it a kind of inaccurate measure of how intensely you're exercising. So if you suspect that this may be you, or you're working out and you're like, man, I can just never get my heart rate over 105, it just won't go, then you should consider using the RPE scale. So this is what the RPE scale looks like. Again, lots of text here. You don't need to look at all of it. This would be a great slide to come back and reference. But this is another way that we can approximate whether we're at a moderate or vigorous intensity of exercise. So if we look at that green strip, well, actually, let me back up and just anchor the scale a little bit for you all. So this is a scale from 0 to 10. There are other versions of it that go to 20. I think the 0 to 10 is easier to use. And this is quantifying how difficult exercise feels for you. So 0 would be, I'm sitting up, feet up on the couch watching a movie. I am exerting no effort right now. Versus 10 would be, this is the absolute maximum that I can do. I'm about to collapse. I could only last for a very short time more at this intensity of exercise. Okay. So when we're thinking about where moderate intensity falls on this scale, we're going to be in that green strip, rating our intensity as somewhere between a 4 and a 6. An easy way to kind of do a self check-in as you're exercising is based on how hard it is for you to breathe and hold a conversation. So if you're exercising at a moderate intensity, you might be getting a little bit out of breath, but you could still talk back and forth with someone who's near you as you exercise. It just might be slightly more difficult. And if we're in that vigorous intensity category, this is where we're going to rate it 7 or an 8. So this is where you're starting to get uncomfortable. This is pretty difficult. And if you were my patient, we were exercising together, and I said, rate your intensity right now on the RPE scale for me, you would be able to answer me and say, I think I'm close to an 8, but you wouldn't want to say a whole lot more than that because the rest of your breathing is just going to be devoted for just that, just breathing. So again, you can utilize this slide to come back to as reference material for that. All right, we'll go back to this slide, and I want to just take a moment to see if anyone has questions on either any of the introductory information so far or any of that aerobic activity information before we move on to strength training. Okay. Going once, going twice. All right, if you think of questions later, we can always come back to them at the end. So next up, we're going to dive into progressive resistance training. So this is the slide listed here are the benefits of resistance training. It's going to improve our strength and power, improve non-motor symptoms, specifically anxiety and depression. It's going to reduce motor disease severity. This is a scale that your neurologist may use when they measure how much Parkinson's is impacting your motor function. It can improve gait speed, balance, and overall mobility, reduce your fall rate, and overall improve your quality of life. Things are just going to be a little bit better. So when we're looking at the nitty-gritty of strength training, here are some of the important things for you to know. It's recommended for strength training to be done at least 2 times a week on non-consecutive days, so don't do it back to back, for somewhere between 30 and 60 minutes, okay? And in these exercise sessions, we should be targeting all of our major muscle groups. So you're thinking your thighs, your hamstrings, your calves, your arm muscles, back muscles, chest muscles, core muscles, right? We're trying to touch on all of those a little bit, okay? But because of the way Parkinson's can impact our overall posture, and I'm sure they talked about that kind of hallmark, stooped forward, a little bit bent posture that people often associate with Parkinson's. We also want to make sure that we're paying special attention to all of our extensor muscles that help us be upright and tall. So these are muscles on the back of your leg, thigh muscles, upper back muscles, right, to help us kind of combat that typical Parkinsonian posture. The other consideration, and why I keep calling this progressive resistance training instead of strength training, they are essentially synonymous, but with the caveat that strength training or resistance training should be getting harder over time. Our bodies are wildly efficient and they like to do only what we're asking them to do. If I tell my body it needs to be good at getting out of a chair 2 times in a row, it's going to be really good at getting out of a chair 2 times in a row. And if I ask it to do it 5 times in a row, it's going to be like, you've never asked me to do that before. So I never got good at doing that. Why would I? It's wasted energy. So we need to keep raising the bar of what we're asking our body to be capable of so we keep getting stronger. So we're going to touch on this in a slide or two, but if you can do 3 sets of 15 with pretty good form, you need to make it harder somehow, okay? So making it harder can look a lot of different ways. We can add resistance by using free weights like dumbbells or kettlebells. We can use resistance bands. We can use machines, or we can just make the task harder. So instead of doing a calf raise on 2 legs, do it on 1 leg. Or if you're doing sit to stands, make your chair lower, right? So there are lots of ways that you can progress in exercise other than just going up in weight. So as we were talking about, how are we gauging difficulty level? One of these ways is thinking about how many repetitions you can do, right? If you can do 3 sets of 15 and it's pretty easy, that's a sign to you that the difficulty level is not enough. You should be bumping up the intensity. Starting with 3 sets of 10 can be an accessible way to kind of dip your toe in and say, okay, how do I feel when I do this? Is it just right, too easy, too hard? And then add 2 repetitions each time you revisit the exercise if that's going well, right? If you do it and you're like, that was okay, add 2 more repetitions next time, all the way up until you get to 3 sets of 15. And then you can make the exercise harder once you get there. So more weight or a lower chair, and bump down to 3 sets of 8, and then work your way back up again and then make it harder again. Okay. One of the other things that we want to be thinking about is how sore are you and how just generally hard is this exercise for you? I want you to keep in mind that when you're doing strength training, soreness is normal, expected, and a good sign that we are actually improving your strength. If you never feel anything when you do strength training, you're probably not doing it at a high enough intensity. Now, that being said, the soreness should only last for 1 to 2 days, maybe 3 if you're kind of pushing it really hard. But pain and impaired function are where I draw the line and say you're doing too much. So muscle soreness, yes. Joint pain, we don't love that. We want to figure out a way to work around that. Or if you do so many squats that the next day you're like, I could not get up off of the toilet to for the life of me. I just could not do it. Then again, it's impairing our function, so we're going to dial it back a little bit from there. These are some examples of exercises that I like to incorporate in individuals with Parkinson's that I'm working with. So a lot of these are very functional for a variety of different reasons. Squats and sit to stands, getting up from a chair is an essential. Rows help to strengthen our upper back muscles that keep us upright. Tricep push downs, I think that preemptively strengthening your triceps can be really beneficial for individuals who may be using an assistive device and they support their body a little bit with their arms, or for getting up off the floor and being able to push your upper body up a little bit to help you get up off the floor. That can be very frustrating if that becomes difficult for you at some point. Calf raises are a good one to incorporate. Our calf muscles are very important in pushing us forward as we walk and keeping our walking energy efficient. So a lack of strength here can really impact your walking. And then again, lunges are just a very functional exercise, strengthening a lot of those extensor muscles that we talked about. These are not exclusives. You don't need to be doing only these. You don't need to do all of these, but these are just a starting point for you. Okay, we'll do a quick pause here at resistance training to see if anyone has questions at this point. Okay, don't jump up at once.
I,
All right.
I'd
Yeah,
like to know if you should do all your exercises in consecutively, or can you do them throughout the day?
Yeah, that is a great question. There can be benefit to both. So doing them all consecutively is going to push your endurance a little bit more, and it's going to be likely a little bit harder in terms of fatigue and muscle working to do them all at once. However, if you are wanting to strengthen all these muscle groups and it doesn't feel accessible or it feels like too much to do them all at once, breaking them up is fine. I also, like I referenced before, I do recommend that people do kind of incorporate movement snacks throughout the day. And one of those reasons is that when we start pushing ourselves a little bit with exercise, we get a boost of dopamine. So I often tell people, if you are feeling like, uh-oh, my medication is starting to wear off, try doing like 10 minutes of high intensity exercise or biking or something and see if you feel better. And that can help bridge the gap with your medication. So, strength training, if done at a high enough intensity, can serve that purpose as well and kind of give you a little dopamine boost throughout the day. So, I guess it depends on what your main intention is with the exercise. If you're looking to really push muscle strength and endurance specifically, grouping them together can help challenge that. And if you're utilizing strength training to get a bit of a dopamine boost throughout the day, then breaking it up can also be helpful.
Don't want to get on. I'm gonna do it.
Any other questions right now?
I don't, hi, I don't have any questions, but I am the caregiver of my husband who has
Mhm.
Parkinson's. And I wanted to tell you what we found on God Love YouTube. It has everything. And we got on YouTube and we have a company that does for Parkinson. It's wonderful. I even enjoy it myself. And it's really wonderful. It has a leader that, she shows you what to do. And for my husband, one of the symptoms he has is not talking loud enough.
Sure.
So she has some that called shout, that so they get your voice going. And then the other exercises too, and it's just wonderful. I'm just saying if people can't get out, I'm saying this is something maybe that they would be interested in.
Yeah, thank you for pointing that out. You bring up a great point that there are tons of exercise resources, especially for folks with Parkinson's out there already, accessible videos at home or other exercise classes. We're going to touch on that a little bit later about how you can really make this your own. And if you find something like that that is working for you, if it ain't broke, don't fix it. If it's something that you enjoy doing, that's the best form of exercise for you.
Yeah, and just one more thing I'll leave you with is on what's nice about it is they do some exercises sitting and they do some exercises standing. So for people to me, when I deal with and being the caregiver, that it's wonderful. It's just wonderful, like I say, because if you do it sitting down, it gives you just as much as if you're standing up. And it's like I say, so if after in the end, if you'd like me to tell you who I connect with, I'd be happy to do that. Okay, thank you very much.
Yeah, wonderful. Thank you for that. We always love sharing resources. It's much appreciated. Okay. Other questions before we jump into balance training? Okay, green flag. Here we go. Maybe. Okay. So listed here are some of the benefits of balance training. So we're looking at improving our postural control and balance, improving our walking quality and overall mobility, improving balance confidence, non-motor symptoms as well, and overall quality of life. So this is the details for balance training about how much we should be doing. A minimum of 2 to 3 times per week is what is recommended by most, but myself and a lot of other physical therapists think that daily can be better. And part of that is because I describe balance training to the people that I work with like trying to make a divot in a rock by dripping water on it. So what's going to be most helpful there is repetition and consistency. But if I were to take a bucket of water and dump it on that pebble, that isn't really going to help me towards my divot that I'm trying to make. So the same thing for balance training. It's less effective to do 3 hours of balance training once a month or once a week than to do a couple minutes every day. So maybe 5-10 minutes every day of working on your balance can give a really big payoff. It also is a daily primer and reminder for your brain that these functions need to come online with you every single day. Challenge level for our balance training also matters. So in this regard, we're shooting for a 70 to 30 success failure ratio, meaning that if I was asking you to tap your foot on a cone, about 70% of the time you're going to do it accurately and without too much of a struggle, although it might be effortful, you're having to concentrate. And 30% of the time, you might not get your foot up there before you lose your balance or you miss the cone or you got to put your foot back down. So that indicates that we're doing something that is challenging enough to make a difference. Research has shown that easy balance exercises don't improve your balance. So you're just asking your body to do something that it already knows how to do. The other thing that research has shown is that minimally supervised and home-based programs, if this is the only thing that you're using to train your balance, is less effective than a supervised program. And this inherently makes sense to me because of what I do as a physical therapist. I challenge my patients in their sessions much more than I would ever want them to challenge their balance at home because they have me and other equipment as a safety net. I always want to make sure that what I'm asking people to do at home is safe for them and not putting them at risk of falls. So inherently, you're going to be able to challenge your balance a little bit more when you have someone else as a safety net. So if we, and each person, we'll touch on this when we talk about PT specifically, each person's balance training needs are going to be a little bit different. So as far as really challenging you individually, having a PT's input can be really beneficial. But some simple exercises that you could start with at home or see if they're appropriate for you are standing heel to toe, standing on one leg. For some people, just standing with your feet close together may be challenging. And then doing something like that and turning your head can actually be quite difficult. I find that a lot of people that I work with can't hold their balance on one leg for a very long time. So this is one that I often recommend that people do. And balance exercises, doing it 10 minutes at a time is great, but you can also just work these in with certain tasks throughout the day. Like every time I brew my coffee, I practice standing heel to toe at the sink while it brews. Or every time I brush my teeth, I stand on one leg at the sink. Brushing your teeth, though, is going to make standing on one leg a little bit harder. So in terms of where to do this at home, the two places that I always recommend are in a corner in your house, and you can place a chair in front of yourself if needed. But that way, you're right up against the wall, just not touching it. If you do lose your balance, you're just going to kind of bounce off the wall a little bit, okay? If you can't find an empty corner in your house, try closing and locking a door so that, no one opens it into you, but that's a way you can create an open corner. And then the other spot that I recommend is at the counter, but preferably at the sink. That way, if you start to lose your balance backwards, you can grab onto the sink and actually get good purchase instead of just scrabbling your hands on the top of the counter if you're falling backwards. So those are the two spots that I would recommend trying balance things at home. Okay, I know I want to leave time for questions if there are any, so I'm going to try to breeze through a couple of these things. So flexibility training. We have a little bit less data on flexibility training, but it is something that is recommended to implement because we know that Parkinson's can cause rigidity and lack of flexibility. So this is also something that I recommend to all my patients because you can do it safely and fairly easily at home. It's not something that you need the guidance of a PT for every time you do it. So if we're thinking about flexibility training, this can be just a couple minutes a day, but we're going to be targeting a lot of those flexor muscles that get tight in that typical Parkinsonian posture. And then calf muscles as well. I also recommend to stretch a lot because when we walk or get up from a chair, we need to be able to get a stretch in that calf muscle to get our foot in the right position. So that can become a lot more difficult if those calf muscles are really tight. And then the other thing that I also talk about a lot is there are a lot of things that people say are normal as we get older. Oh, it's normal to move slower, or it's normal to be a little bit off balance or have a hard time with things. But in reality, that normalcy with aging is often more related to reduced activity levels than aging itself. There is one exception to this, though, that I talk about. Well, there's more than one, but the one exception that I reference frequently is that as we get older, our tissues become less elastic. So when we're stretching, this is something that we have to keep in mind. I'm sure many of you played sports when you were younger and you stretched, this way for 10 seconds and this way for 10 seconds, but that's not going to cut it for us anymore. We should be holding these stretches for at least 1 minute in the same position without bouncing or coming in and out of that stretch to allow these tissues that are a little bit less elastic to really relax into that stretch and help improve the length. So here are just some examples of stretches that I like to recommend frequently. Stretching the back of our knee with a hamstring stretch, a calf stretch up against a counter or a wall, a hip flexor stretch where you're really stretching out the front of that hip. That one can also be done in that kind of Same position of the calf stretch, but you're just really targeting your hip instead. Trunk flexibility, there's the most data for flexibility about decreasing trunk rigidity. So this exercise here is an open book where you're kind of twisting through your trunk to get some rotation there. And then a stretch for the front of your chest. It's pretty easy to do in a doorway. You can put your hands as high or low as is comfortable for your shoulders, and then step into the doorway a little bit to stretch out the front of your chest and help us with that upright posture. Okay, so I'm going to do a quick pause for questions if anyone has any burning ones right now, but we're getting close. Okay, go ahead and interrupt me if you have any. But that's a lot of different recommendations for exercise. And I want to just kind of, if we're thinking about what is best for each individual, I want you guys to do what you like, right? If I told you you have to do 100 burpees a day and that is the best exercise for Parkinson's, most of you would be like, I'm just not going to do that. That's not something that I'm ever going to do. That would be understandable. So the best kind of exercise is whatever exercise you are actually going to do. That is what is going to be most successful for you. So it doesn't have to be going into a gym and doing strength training there. It can be other ways that you're working on improving strength, or we're going to kind of in a slide or two provide some other examples of types of activity that can be great in exercise classes or different things like that. But it doesn't have to look like what is on these slides to be beneficial, especially if what's on these slides is not something that you enjoy. We also know that not only are you going to do exercise that you enjoy more consistently, but we get a bigger dopamine boost when we do exercise that we enjoy. So it's really important for you to find something that is enjoyable and sustainable for you. Again, that also helps with motivation. As I talked about before, motivation can be hard for individuals with Parkinson's because we're taking away some of the chemicals in your brain that you need to be motivated. And it's also hard when movement can become harder. And so it's disheartening to try to exercise when you feel like moving is hard. So anything that helps to improve your motivation is going to be beneficial. Exercising with other individuals with Parkinson's can be incredibly motivating. Finding a routine and sticking to it can help to decrease some of the decision fatigue of, well, am I going to exercise today or am I going to do it tomorrow, right? If you just know that Monday, Wednesday, Friday, you do this type of exercise, Tuesday, Thursday, Saturday, you do that type of exercise, and you don't have to think about it, that can help as well. And then again, doing whatever is feeling good and you're enjoying is the most important thing. The next slide is just a plug for PAR's online class database so that you can find one near you, but they offer a lot of varieties of classes that are, Tai Chi, yoga, dancing, boxing, other just exercise classes, different things like that. And you can kind of pick and choose those based on what you feel you need the most. So whether it's balance, agility, endurance, that kind of thing, or you're concerned about the safety of exercising, then you can kind of pick and choose what fits best for you based on what you need. So again, if you live in this area, then going to this website, and I think Phyllis mentioned this at the start, that they have a really great database on here where you can find ones that are close to you. But I just, in case anyone missed it, I wanted to revisit that. And not only does it make exercise more accessible and fun and personalized for you, but there's a lot of data out there that supports for individuals with Parkinson's that community exercise particularly has additional benefits. It can help with decreasing feelings of isolation and depression, which we know can be a common theme in Parkinson's, help with some of that hopelessness that can rear its head. And it also can help with that motivation that we talked about, that consistency and accountability. If someone is not class and they're like, hey, where was Chuck last week? Why wasn't he here? Is he okay? Or, there are people in my exercise class that that surgery, and everyone's reaching out to them and saying, hey, how did your hip surgery go? When are you coming back to class? We're thinking about you. So that can really help to form a strong community and give you some support in that way. I'm going to do this really briefly because I know we're getting short on time, but when to start physical therapy? I think as soon as possible. I think it's great to establish a relationship with a therapist so they can have eyes on you and do a really comprehensive assessment. And then personally, I recommend a burst care format. So we might be together for a couple months the first time to kind of work on things that we identify, but then I recommend that they come back somewhere between 6 to 12 months so we can reassess. That way, if there's any change happening, we can identify it right away and address it as soon as possible, rather than waiting until you start falling or there's a bigger problem. And I think when possible, seeing someone with a neurologic background or a Parkinson's specialty or lots of familiarity with Parkinson's can be really beneficial. And then if you're not even planning to go back to therapy, but you've noticed, like, man, getting off the floor is getting harder, that's a great sign. You know, any kind of task getting harder to revisit physical therapy. I just want to put a little plug in for the other therapies that can be beneficial. So, speech therapy, which works on speech production, like you were talking about earlier, with that quiet voice, so they can work on the volume of speech. They can also work on swallowing impairments. This is really important for preventing pneumonia. I'm sure you guys have heard that Parkinson's itself is not fatal, but what does often end up causing individuals with Parkinson's to pass are falls and pneumonia. So I am a big advocate for PT and speech therapy to help address that as much as possible. Speech therapy can also work on cognitive function as well. So if you notice, well, I'm forgetting a lot of things, go get a speech therapy appointment. Occupational therapy can be very helpful in addressing all of our activities for daily living. So grooming, showering, medication management, making sure your home setup is safe, all of those kinds of things. So I recommend a consultation with all three of them as soon as possible. And it might be a one-time visit, or they might say, hey, I found some things that I think we should work on. Are you up for that? Big takeaways. I'm not going to read all these to you guys. I know you can read all of it, but the most important thing is exercise really truly is the best tool that we have to delay disease progression. So it is, I think, the most important part of your routine because it's going to give you as many years as you can, feeling as good as you can. If you can hit on aerobic strength and balance training, that is awesome. But what is most important is starting somewhere, no matter where it is, and doing something that you enjoy so that you'll do it with consistency. Here are my references. You can look back at them later if you would like. And then this is my email in case anyone has questions or things they want to talk about outside of the presentation so that you all can reach out to me. It's much better to get a hold of me via email than trying to call me because I bounce to a couple of different clinics. I know we're short on time, but I'm happy to answer any questions if anyone has any that were not asked or answered already.
How often do you recommend physical therapy? I mean, like once a week for a certain stretch, or I'm just
Yeah, that's a great question, and I think it depends on what you're working on in physical therapy. I have a lot of people who are really mobile and newly diagnosed, and they might be individuals that I see once a week or once every other week, and I'm just kind of helping them fine tune their exercise routine, but they're doing the bulk of it outside of therapy. I have other individuals where I'm really working on their balance really heavily. And to do that, I usually schedule at least 2 times a week so we can kind of work towards that higher frequency because that is often less accessible to do at home. So for those individuals, I often work with them 2 times a week for 10 to 12 weeks for the first bit. And then we develop a routine for them to do independently after that until the next time that we check in 6, 9, 12 months. But it really can be customized to what you need.
thank you.
I have a question. The person that I'm a caregiver for signed up for physical therapy and did it for about a month or maybe 3 weeks, and he also did other things. And his physical therapist said that he wasn't in need of physical therapy. He was doing just fine and canceled the physical therapy. So it led me to wonder if someone isn't quite at the so-called physical point of looking like they need physical therapy, how do they get approved to keep on doing the physical therapy to keep preventing progression?
Yeah, I think that's a great question. My default is always to assume the best intention from this physical therapist, and maybe this individual is doing phenomenally and has a great exercise routine that they're doing on their own. If you're not sure that that's the case, it never hurts to revisit therapy with another therapist and see what they think as well. That situation sounds like it would be a really good time to look for someone who has worked specifically with Parkinson's or has a neurologic background. Because I often find that I'm seeing individuals that would probably be fine without therapy, but that's when I start working on preventative things or really making sure they're maximizing their exercise routine. I think I could pick anyone off the street and find ways to challenge their balance. And we know that overtraining, strength, balance, endurance can be really beneficial for individuals with Parkinson's. So I would, give yourself some permission to push back and say, I'm not sure that that's right. And I want to have someone else give an opinion. And so I would shop around a little bit for another neuro-specific PT that might be able to find ways that therapy is beneficial.
Okay, thank you.
Yeah.
I might ask both you and Phyllis,
Mhm.
how do you find someone that is has experience with Parkinson's? Do you have recommendations, or does PAR have any recommendations that they can give you, or are you just on your own to find somebody?
Yeah, Phyllis, go ahead and answer that
Yeah,
first.
in most of our areas we do have lists, resource lists of providers. It just kind of depends on where you live. If you live on the Western Slope, I could work with you on that. If you live closer to Denver, I can. Well, Kim Hall can probably help you with that. She's going to be coming on and speaking in a minute about resources. So. Yeah, we definitely please do consider us, a first stop. When you have questions like that, we'll do everything we can to, help you find the right people.
Yeah, we had a great physical therapist and he retired, and we haven't been able to find anybody that was as good as he was. So anyway, we'll get in touch. Thanks.
Okay, thank you.
Another option is the American Physical Therapy Association has a tool called findaneuropt.org, or it's neuropt.org, but the website is Find a NeuroPT. So you can go onto that website and search up Find a NeuroPT, and that may also connect you with people who are in your area that have neurologic certifications as well.
Very good advice. Okay. All right. Are there any more questions? Well, Sierra, thank you so much for your expertise today. We really appreciate you. That was so informative. And thank you again. Just that was great. So
Yeah.
thank you. And now we have another speaker coming up. Her name is Kim Hall. Kim is the Director of Social Services and Social Work at Parkinson Association of the Rockies. She's had a long career with neurology, as she was the executive director of her own nonprofit working with individuals who have epilepsy and other neurological disorders. In addition to her numerous CEO duties, Kim invited keynote speakers to many conferences about epilepsy, behavior, and mental health. Her education background includes an associate degree in pre-law and criminal studies and a bachelor's degree in psychology and counseling. Kim earned a master's degree in social science neurosciences with a dual discipline program with concentration in psychology and medical history. She is certified by the state of Colorado as a social worker for children and families, and she was chosen as the Outstanding Female Graduate of the Year by the American Association of University Women and selected to attend Harvard University for a semester. So we're very honored to have Kim here with us today. So please welcome me and join me in welcoming Kim.
Well, thank you all, and what a nice crowd we have this afternoon. Appreciate all of you taking time out of your day to attend. As this program gets going, a candid conversation about mental health and Parkinson's disease. And as we go through this, I think what I will do is probably have you give me questions at the end. If your question is not answered, I'm going to ask Phyllis to put my email in the chat so that if you do not want to say your question online, because this is being recorded and you just want it to be private, please send me an email and I'll be happy to connect with you. So with that said, I'm going to do a few definitions around what is Parkinson's, which we all know, but and then what is mental illness. And I'm going to take a long look at when you are looking through the lens of Parkinson's at some of the mental health challenges people can have and experience. And then, of course, some of the more common things that we hear about in hallucinations and delusions regarding Parkinson's. And then how do you have a candid conversation with someone, a loved one, about their mental health struggle and their Parkinson's disease? So with that, I'll get started. Parkinson's disease is a progressive, incurable neurological disorder, right? We all know that. When the brain cells that produce dopamine either die or are diminished. And many of you are familiar with the symptoms that can come along with that, both motor symptoms and non-motor symptoms, everything from tremor to freezing, to non-motor of constipation, maybe loss of taste, loss of smell, anxiety and depression. And then for the purpose of this talk, mental illness is going to refer to and be defined as diagnosable health conditions, all right, spanning from mild to severe. And sometimes people move along that continuum, either because of their lifestyle management or medication management, or both, right? They can significantly interrupt a person's thinking, their feelings, emotional state, mood, behavior. So it can often impair daily functioning and such as work activities, daily activities, social activities. And often they are not just passing reactions, but they are long-lasting and for some people, a lifetime of necessary treatment. And sometimes the treatment also includes both medication and then talking therapy of some sort. All right, so maybe a cognitive therapy for someone, a behavioral therapy for another person. I always like to give a little asterisk here that this is not caused by personal weakness. Mental health issues are not caused by personal weakness. So, core areas affected: thinking, mood, behaviors, and feelings. The functional impact: it can cause people to not be able to work. They might not want to go out of their homes into social activities. It can range from mild to severe, and some are very serious mental illnesses. Common disorders do include anxiety, depression, bipolar, obsessive compulsive disorder, and schizophrenia. Okay. Now, what the common warning signs, and many times I hear people say, oh, he's just so sad, or he suddenly became sad, or he had a extreme mood change, or they notice that the individual is becoming more and more isolated socially, maybe confused thinking, reduced concentration or paranoia, significant changes in sleeping or eating habits, and excessive fear, anxiety, or guilt. Now, those last things that I just said, many of you are probably saying in your mind, or you know someone, or you caregive for someone. Is that mental health, or is that Parkinson's? Or is it both? So we're going to talk about that here shortly. So keep that, if you are taking some notes, keep that on your notebook. Again, another important context is, while it is also is not a personal weakness, please note that it is not a character flaw. It is not a choice. They don't have a choice in this. This is something that happens to them. It is an illness, just like a physical illness. Okay? So, just like people go to their MD, their family physician, their internist for treatment when they're ill. People with mental illness also need a psychiatrist or a psychologist to help them through that period. Some of you may be surprised to learn that the prevalence of mental illness is 1 in 5 adults experience mental health issues. And I could have gone a lot of different ways in talking with it about mental health, and I would have been talking for, well, a week or so, but I'm sure you all want to have dinner. So I often refer to the 5 Ds of mental illness. Deviance. So behavior that significantly differs from what is considered socially or culturally normal. So, someone has deviated from the norm. You thought of them as an everyday average individual, and then suddenly maybe they went through menopause and they had a huge deviance of behavior. Distress. Many of you will recognize distress in someone that you love who is going through an emotional crisis. Intense anxiety, sadness, fear, maybe experiences that the individual you know and care about is experiencing. How about dysfunction? Another big D. impairment in daily life, work, school, relationships, or self-care. How many times have any of you heard someone say, boy, Sue just really let herself go? What happened? Right? Well, did she really let herself go because she's just making a choice about that, or is she suffering a emotional crisis? Danger. Now, this is when behaviors become dangerous to themselves or others. And obviously that is a emergent situation where 911 and law enforcement and maybe adult protective services would need to be involved. Okay, and then the duration. Now this is important. The persistence and length of time of the symptoms that have been present, indicating a significant change rather than a temporary issue. So, many times when someone is diagnosed with a disease or a disorder such as Parkinson's and they become depressed, we in the mental health world might classify that as situational depression. Or someone has experienced a loss. Many of you have been to my grief and loss group. Many times people that come to that group are talking about a situational period of time. It's short, temporary, but it can happen over and over again. However, when we're talking about much more involved and serious mental health issues, we're talking about something that is much longer in duration and really requires specific, specialized treatment. Okay? Does that make sense to everybody? I see some people on and shaking their head. Okay, good, good. So let's look for a moment at mental health through the Parkinson's lens. Over the course of working with people who have neurological disorders and diseases, and especially in Parkinson's, I hear a lot about individuals suffering from depression and anxiety. Okay. Again, for some of those individuals, it can be very situational and temporary. And for others, it can be a longer period of time that is now causing them, in addition to what's happening in Parkinson's, it's causing them a mental health crisis where they may need to be medicated with a antidepressant or an anti-anxiety medication. All right. So when I am talking to you and using the term situational depression, I'm talking to you about an adjustment disorder. It's short term, stress-induced reaction oftentimes. Obviously, the diagnosis of Parkinson's in this case can cause a lot of stress for people. And so then they have this situational or adjustment disorder type of depression. It also can happen with specific life events. For example, job loss, divorce, loss of a pet, loss of a friend. All right, those kinds of things. Sometimes loss of a parent, So that can be a situational depression. They go through a period of time where they're extremely sad, hopelessness takes over. Many people report like a cloud hanging over their head. But then the sun breaks through at some point for some reason again, right? The sunshine comes out for them. On the other hand, clinical depression, which is a major depressive disorder, is often long-term. And that's like what I was saying, when people need treatment for the rest of their lives because they have a major clinical depression. It's often genetically or chemically driven. Interesting, with severe pervasive symptoms lasting 2 weeks or more. Now, the reason that this is interesting is what's the major neurotransmitter that is affected in Parkinson's? Dopamine, right? So many people get that double whammy. And so not only are they dealing with this neurological stressor, but now, not because of dopamine and possibly a serotonin issue, and in some people, the neurotransmitter GABA, they all collide. And they make for a great big explosion. And so when that happens, it's really hard to get people involved in activities. So you just heard about exercise, how wonderful that is in so many ways for all of us, but especially people with Parkinson's. Well, if you've had this big bang in your brain, and the last thing you want to do is join an exercise class or go to coffee with friends, or when a friend calls, or someone calls you, you don't want to answer the phone. So you can see that there are a lot of issues happening, and we don't always know which is which, right? And it takes a real good team to figure that out. So both of the situational depression and clinical depression share symptoms like sadness and fatigue, which, if you've ever known anyone who's been very, very depressed, one of the signs that they show is that they want to sleep a lot. You know, they want to stay in bed all day. They lose interest in life. They lose interest in the activities that they used to have. They don't even really want to watch a TV show, and they used to love to watch TV all day. So watch for these following symptoms that may signal that it's more severe, and it probably will require medical intervention. So those are continued sadness and hopelessness, frequent crying, lack of motivation, and withdrawal from social activities, fatigue, and changes in appetite or sleep patterns. So, and that appetite deal can either be a major weight gain or a significant weight loss. And sleep patterns that get all out of whack. you knew this individual as someone who went to bed every night at 10 or 11 o'clock and got up at 6 or 7 the next morning, and they were fresh and they slept all night, didn't really have any issues throughout the night, and now suddenly they are up all night and asleep all day, or they're sleeping all the time, both day and night. So you really want to watch for those kind of serious red flags, the alarm bells. Now, for those of you that have been to my grief group before, you know I talk about grief being a natural response to loss. It's just natural. It comes and goes. Everybody experiences grief differently. There's no one way to say, oh, you're doing it right, you're doing it wrong. That's not how we grieve. You grieve as an individual, and we all grieve and experience loss because we're human. Doesn't necessarily have to be because you have Parkinson's. We all might have had to give up that first pet, or we moved away and our best friend was still in the town we moved away from. Many of us, when we were fresh out of college, we might have thought, oh, the job I'm in is the one I'll always be in. So there's constant grief and loss. And then when you come in to grief and loss in Parkinson's, as one of our group members said, and he said that I could steal this from him and kind of paraphrase it, but he summed up the grief in Parkinson's as Groundhog Day. Grief is like Groundhog Day. It's just happening over and over and over. It might not be the same kind of loss each day, but they're loss of independence, loss of your job if you are a young person with young onset Parkinson's. Maybe some loss of relationships, friendships. What if you have to move from your home to a care community or a retirement community because you can't take care of yourself anymore? All kinds of losses. The loss of not, if someone once said to me, well, I know I'm not the man she married. Okay. Well, if you're growing and changing, that's a positive, right? You're not the same person you were when you were 25 or 30 and got married. But if you are looking through the lens of Parkinson's, you might be having some real difficulties with that. And the change of that individual, they're changing right before your eyes if you're a care partner. How do you stop that? How do you put the brakes on? And you can't. So, just remember that you might start seeing some things around grief and loss that look like real angry behavior. Okay. Naturally, they might not feel worthwhile. A real sense of sadness, depression, anxiety. So now I have just given you acceptable terms in Parkinson's, when just a few minutes ago I talked about, well, let's watch for these, and it might be a medical emergency or medical intervention is needed. So write down on your paper, how do I tell the difference? We're going to talk about that. Yeah, and I'd like to give you a quick definition for your notes about depression and anxiety in Parkinson's. So depression and anxiety are common, treatable, non-motor symptoms of Parkinson's disease, affecting a significant number of patients due to brain chemical imbalances, dopamine neuron loss, and the stress of managing a chronic conditions. These symptoms are often undertreated, requiring tailored medication, for example, SSRIs, therapy, exercise, and social interaction to improve quality of life. And I'm going to say that one more time for you. So, depression and anxiety are common, treatable non-motor symptoms of Parkinson's disease, affecting a significant number of patients due to the brain chemical imbalances, specifically the dopamine neuron loss and the stress of managing a chronic illness. These symptoms are often undertreated, requiring tailored medications, for example, the SSRIs, therapy, exercise, and social interaction to improve quality of life. I cannot stress enough that therapy, exercise, social interaction are key to improving quality of life. Now, when a person has Parkinson's and they come to see me, I don't necessarily, in fact, almost never, do I think about medical intervention with someone because it is a part of their Parkinson's. Okay? However, there are cases when it's quite severe and we need to involve other team members. So maybe a psychologist, a psychiatrist, or a neuropsychiatrist. So with that, before I go into the part about Parkinson's progressing and hallucinations and delusions, how about I go ahead and say any questions right now on that first part? And was that first part helpful for people in understanding some of the connections between mental health issues and Parkinson's disease? Anybody have a question? No?
Could-
Yes,
do.
go ahead, Julie.
Could you repeat what you said after chemical changes and imbalances, loss of dopamine and neurons? The next sentence?
The neuron dopamine.
Yeah, but the next sentence after that?
Yes, I sure can. And the stress of managing a chronic illness.
Okay. Thank you.
Yeah. Anybody who has a chronic illness, whether it's Parkinson's or some other chronic disease or disorder, they do find themselves having a lot of stress because there's a lot to consider. As all of you who are either a care partner to someone with Parkinson's or an individual on this Zoom today living with Parkinson's, there's a lot of stress. There's a lot of layers. There's a lot of things to manage. And so, you can see why social isolation becomes a big part of this, right? They just think, many people just throw up their hands and they say, I'm not going to deal with the world today. Or I'm not going to adult today. I'm going to stay in and go back to bed and pull the covers over my head. Okay. Good question.
There's a question in the chat, Kim.
Yeah, the concerns about the side effects or the interaction between Parkinson's medications and antidepressants. Fortunately, there's not a lot of people do not experience major interaction problems with antidepressants and Parkinson's medication, mostly because your Parkinson's medicines are directed towards dopamine, and your antidepressants are almost always directed towards serotonin. And sometimes they're directed towards GABA, okay? But serotonin. So it's not to say that that does not happen, because there are people that can't tolerate medicines for one reason or another, and they start to begin to have an interaction. Often in those cases, they get moved to another medication, which works just fine. Does that answer your question, Jennifer? Okay. Anybody else before I move on here? All right. As many of you know, hallucinations and delusions are very common in Parkinson's disease. It is considered a non-motor side effect or symptom. They affect about 50% of people with Parkinson's disease. They can appear as minor visual distortions, such as seeing shadows or animals, or presence, or they can present themselves as presence hallucinations, meaning feeling someone else is in the room with you, or actually, for example, right there in bed with you. Okay. This is usually caused by a combination of disease progression, so neurochemical changes, and the side effects from the medications that people take for Parkinson's. So the carbidopa, levodopa, the brand name Sinemet. Okay. So you have that aspect of it. Some people have the aspect of that the medication is at the root cause of their hallucinations and delusions. However, not always. Now, as Parkinson's progresses, many experience significant confusion, significant cognitive decline, hallucinations, or delusions. And delusions are typically not as present, but you should be mindful that people do experience these, and they are often talked about as paranoia Someone may say, I know someone's trying to hurt me or hurt you, kill you. I know the guy at the meat counter is flirting with you. He wants to take you out on a date, you know, those kinds of things. So, or for example, it can also be the IRS or some other governmental agency is controlling my thoughts or can read my thoughts. They're trying to steal my money. So those are delusions. And while they are not as prevalent, they do happen in Parkinson's. So, Phyllis, Jay put something in the chat about how can you tell the difference? Or what was his question about that?
Is the determination that one has, okay, let me try that again.
Okay.
Is the determination that one has Parkinson's and not mental issues important?
Yes, it can be extremely important. And let me give you an example here. Sometimes people go to the doctor and they're presenting with hallucinations. Not real bad yet, but they let their physician know that they experienced something while they were at home, and suddenly there was 5 or 6 people watching TV with them. And so the next time at the doctor, they relay this experience. Now, if their doctor knows something about Parkinson's, they're probably going to say you need a neurological exam before they send them to a psychiatrist. If your regular physician, your general practitioner, doesn't know much about Parkinson's, he may send you to a psychiatrist first. Hopefully, that psychiatrist is going to have you submit to a good neurological exam. But it is very important, Jay, to distinguish the two. However, just remember that once you have been diagnosed with Parkinson's, the likelihood that you will experience hallucinations and or delusions is 50%. I mean, that's quite high. So, and the older that you get and the more your Parkinson's progresses, the chances of you developing them at some point in your disease journey is likely. Okay. Sometimes treatment involves adjusting your Parkinson's medication and improving sleep, reducing stress, exercising, things that we've been talking about over and over again, right? Good nutrition can help. Making sure you're taking your medication at the time that you're supposed to take it. So getting into a routine. One thing that has come up in studies recently, for cognitive function in Parkinson's, the presence of dementia significantly impacts survival, with hallucinations at the onset of dementia predicting shorter survival. Okay. Now, it's not to say that if you have young onset Parkinson's, that you cannot be one of the people who experiences hallucinations and delusions. It does happen to that group. We just happen to see it more often as people age. And so with that part, you probably either know someone or are caring for someone that has experienced this. So what I would like to recommend here is well, before I go further on that, let me just remind people, if you know someone or you're a care partner to someone who has hallucinations and delusions, please, please, please do not argue with them. Do not try and tell them their experience is not real. Simply give them the respect and dignity and try and help them through that period, that because it's a real challenge for them. So if someone says to you, don't you see those 3 people that are sitting in here and talking with us? Rather than saying, no, I don't see them, say something like, can you point out where they are in the room? So help me find them. What are they wearing? Give them an opportunity to talk about what is happening to them in that moment. Too many people say, oh, that's not real. Don't be that person. So to sum it up here, and then I'll take a few questions. People with Parkinson's can have both a separate mental health disorder on the left hand, and they can have Parkinson's on the right hand. They are much more likely, if they had mental health issues earlier in life, to experience them as a separate entity when they develop this neurological disease of Parkinson's. All right, so you have that. If they have never experienced a significant mental health issue, and I'm not talking, remember, we talked a little bit about the situational where maybe they've experienced a loss of some kind or things of that nature. I'm not talking about that. I'm talking about individuals who have never really had anything significantly that impacted them emotionally, that someone would say, oh, you're depressed or you're sad or you're this or that. Nothing. But then Parkinson's comes into their life and suddenly they're experiencing some of those things, especially the grief and loss of Parkinson's, of who they are. They are experiencing maybe some depression and anxiety about this disease in their life. Those folks tend to fare much better, and many doctors tend to not put them on a medication for their depression and anxiety right away. They kind of let it run the course, and because they are they're introducing Parkinson's medications, and they want to see how that works, right? And so they don't want to introduce a carbidopa levodopa agent and a Wellbutrin, for example, unless it's absolutely necessary. So with that, does that make sense? And may I take your questions? We'll look forward to the next time, Phyllis. Thank you for having
Thank you, Kim. Thank you so much for sharing your expertise with us today. This was incredibly informative. I think everybody got a lot out of this session. So thank all of you for being here. I just want to remind you that our website is available where you can find out information about support groups, exercise classes, and educational events. Um, so please, please check out our website if you haven't done so already. Feel free to reach out to me or Kim if you have any more questions. And I have recorded this, so I will send you the link tomorrow. I'll have it posted on YouTube in case you want to go back and refer to anything. So once again, thank you, Kim. Thank you, the rest of you. Have a wonderful evening.
Thank you.
Thank you.
Thank you
Bye.
very
Thank
much. Bye-bye.
Bye.